Tēnā koutou katoa. Welcome to this Department of Public Health, usually Friday, but this week Tuesday, lunchtime, usually seminar, but this time it's a webinar. I'm Cherie Gibb, I'm a Senior Research Fellow in the Department of Public Health, and I'm going to be chairing this session. We're really lucky today to have Dr. Jim Thomas from the University of North Carolina here to talk with us. Jim is an Associate Professor of Epidemiology at the University of North Carolina Gillings School of Public Health. He was one of the authors of the American Public Health Code of Ethics, and he served as an ethics advisor to the director of the US Centers for Disease Control and Prevention. He has a strong interest in public health ethics, and he's going to talk to us about that today. It's very topical, so we're really glad to have you here, Jim. Thank you for coming along. Thank you for being so flexible and accommodating. This seminar has been rescheduled several times, so we really appreciate that you were able to get here in the end and talk to us. I think a lot of people have a really strong interest in this topic, and particularly at the moment with everything that's going on with COVID-19. So we're really looking forward to hearing what you have to say. For the audience, there will be an opportunity to ask questions at the end. If you have questions during the seminar, you can type them into the chat box, which is probably on the right-hand side of your screen. And I'll be back at the end to help with the questions and to help read them out to Jim. Other than that, I think that's about all for housekeeping. I will hand over to Jim to talk to you. Thank you.
Thanks, Cherie. Is it time for me to share my screen? Okay. So before I share, I wanted to tell you that one of the reasons that this talk got arranged was because I was going to be in Wellington and be with you in person, but then COVID-19 intervened and we canceled our trip. So we salvaged a little bit of it here. So I'm glad to be with you, at least in this fashion, and maybe next year I'll see you in person. So here we go, sharing screen. Are we good to go? Okay. So I'm, as advertised, I'm going to be talking about ethical pandemic control. And I want to start by mentioning some differences between medical ethics and public health ethics. Medical ethics gets a lot more press, a lot more attention. There's more known about it, and so it's helpful to understand how public health ethics differs a bit from that. In medicine, the ethical issues come out of the imbalance of power between the patient and the provider, and so the provider can speak languages that the patient can't understand and prescribe things that the patient doesn't understand, and so we preserve the patient's autonomy to be able to say no in those situations. In public health, it's not a one-on-one, one-person-to-one-person relationship. It's the whole state infrastructure and the residents of that population. And because infectious diseases can travel from one person to another by definition, the autonomy that is so guarded in medical ethics is tempered a little bit in public health ethics, because we sometimes have to constrain a person's autonomy so that they can't infect other people. And we keep track of the good of the community in public health. So the value that rises to the top in public health ethics is interdependence, as opposed to just plain autonomy. And this is where the challenges come in public health, because countries and cultures will vary in how much weight they give to these two things. In America, for example, we will bend over backwards to protect the autonomy of people. In China, they might give less weight to autonomy. So cultures differ in how they fall on this continuum. Now, it was mentioned that I was involved in writing the Public Health Code of Ethics for the US. This is the cover for the revised version that just came out last year. I was also involved in the revision, and I'm going to be referring to it in this talk. I'm going to be pulling excerpts from the code, exhortations, if you will, from the code about things that should be done in public health, how we should behave as we are administering public health. It was not written specifically for a pandemic, but you'll see there's a lot of material in there that is very relevant. And then I will also be pulling from these documents here, which represent consensus discussions about pandemic ethics specifically. The one in blue on the left comes from the WHO. The title, which you may or not be able to read, is Ethical Considerations in Developing a Public Health Response to Pandemic Influenza. In the late 2000s, we were the world, not just the US, but the world was preparing for a pandemic of influenza. And there was a lot of preparation, including ethics preparation on how will we allocate things like antivirals and vaccines once vaccines become available. And then, of course, all the other standard things like social distancing. So that was done at the WHO level. There was one done in Toronto, Stand on Guard for Thee, in Canada. Because they had dealt with, oh gosh, it's escaping me now, SARS, there you go. It was still fresh on their minds, and so they were writing in here about their lessons learned from SARS. The one in the back there, the yellow one, is from a group across the U.S. that gave thought to ethics in the hospital setting in the instance of a pandemic. And then in the bottom right is the Center for Disease Control and their consensus views on ethics in a pandemic. So I'm going to be pulling bits from maybe not all of these, but most of these as we walk through this. Now I have separated or staged a pandemic into 4 stages. First is preparation before the epidemic happens. Let me just say, I'm going to switch back and forth between epidemic and pandemic. There are gradations between them. An epidemic can affect a single population. A pandemic supposedly affects a world population. But please forgive me if I slip between the two of them. So the first stage is preparation before the pandemic occurs. The second stage is when actions are taken, when they're begun in the community. The third is when a lot of the action takes place in hospitals. And then the fourth is the aftermath, after the epidemic. So I'm going to give you 3 instances of ethical exhortations or guidance or principles in each of those 4 stages. And the first one here, as we're looking at preparation, is preparing for prompt action. And one of the things that, hold on a second, I'm just checking, yes, I'm in the right place. One of the things that's important in the Code of Ethics is that public health departments are to detect, recognize, and acknowledge, your picture is over the rest of that slide, acknowledge public health threats promptly and efficiently. As we look at the news from the US, we find that it hasn't quite gone that way for us. We have intelligence reports that show that the federal government was informed of a potential pandemic in early January, and nothing was done much until early March, a little bit in late February. And so there was a great delay where the pandemic was downplayed and in some cases denied that it was going to affect us. And that created a big delay in my country's response. Now, New Zealand, you all did it differently, and I praise you for that. But this is the way we did it. And time makes all the difference in the world, as you can see in this slide here, where it's comparing San Francisco and New York. Now, first of all, you just run your eyes along the bottom. You can see that there's the month of March, and around March 16th, you can see that San Francisco Bay Area put in place the practice of shelter in place, which is what we are all doing right now because we're watching this on Zoom. And it did not occur in New York City at the same time, although they had roughly the same number of cases. They waited another 6 days. And in those 6 days, you can see how the numbers of cases exploded. And once they put into practice stay at home, a very similar policy. Once they put that into practice, it was too late. The epidemic was already running wild and had spread throughout the city, which is one reason that New York City is in the news for its lack of resources and running out of resources in the New York City hospitals, and why we see refrigerator trucks parked outside the hospitals because the morgues are overwhelmed. It was those 6 days that made it so for New York City. So reacting quickly and definitively makes all the difference in the world. Now, this brings to mind an issue that we have in public health that I've called the problem of zero. This is the bell curve. It's supposed to represent an epidemic curve and the number of cases. And on the early side, on the left, when there aren't any cases, the population typically will think, or maybe policymakers will think, that there's no problem. Why do we need to do anything now? And once the epidemic has run its course and you're on the right now with the lower number of cases, again, you're returning to zero, and the thinking is, well, I'm glad that's over. Let's put our efforts and our money elsewhere. So the problem I've been talking about is on the left side, where we don't really discern what the epidemic is going to be like, and little action is taken. Another point in the Public Health Code of Ethics is to provide adequate institutional and professional support to enable competent performance. Well, here is a table of empty positions in the federal US government, positions that have not been filled. This is, if you turn your head sideways and look at the URL there, you can see that it's an appointee tracker for the US, and I clipped this bit, I think just 2 days ago, so it's pretty up to date. And you can see throughout the many departments that there are many absences. And even where those absences, even when there are people, it's often with a high turnover and a loss of institutional memory. So the federal government is not nearly as prepared as it could be to address something as monumental as the pandemic that we are facing. And then there's ethics preparedness, a third principle of preparation for a pandemic. Public health says that we should establish formal structures such as ethics committees to address and resolve ethical disagreements and challenges, and to enhance organizational ethics and decision-making. Now, when we were preparing for the influenza pandemic, there was a lot of that preparation going on. We're going to be seeing some bits from those documents in just a minute. What was more uniformly done by all of the 50 states of the US was preparation of pandemic plans, not pandemic ethics plans, but pandemic plans. And I did a survey, a scan of all 50 of them for ethics language. And the result was pretty underwhelming. There weren't a lot of plans that had much to say about ethics. And sometimes what they would say is something to the effect of, somebody ought to be thinking about the ethics, and without going into the detail. There were a number of them that said, we will think about the ethics and we will prepare, and we're going to have that ready shortly. So a few years later, I looked to see whether those states that had made those kind of aspirations clear, whether they had actually delivered on their aspirations. And this article here is the result of that. I found that there was very little progress. There was some, but by and large, there was not. And it goes back to that problem of zero, because the pandemic didn't materialize and attention was turned elsewhere. The states where there was progress, the thing that was most clearly consistent between them was that there was a state health director that was very vocal about public health ethics. It was clearly a priority of her or him. That made all the difference. So we come to a point at just before the epidemic is occurring, or the epidemic has started, and America got caught with its pants down. Now, this slide here I'm showing you, I don't know if it has reached New Zealand. It's been viewed over 3 million times here. Well, over 3 million times on the internet. We don't know where. And this was a woman who was involved in a Zoom call, as we are now, and she had it on video, and she picked it up, and she had to go to the bathroom, and she didn't turn it off. And so out of deference for her, I have blocked out the embarrassing portion of her photo over there on the left. But if you look over to the right, you can see on the 3 rightmost women with their hands covering their mouths, just shocked at what they were seeing. And this is like a metaphor of what my country and other countries and cities have been experiencing. They've been caught with their pants down as this epidemic has caught them by surprise. So now, let's go on to the community stage, because now the pandemic is occurring. It's first appearing in the community, not yet a lot of patients in hospitals. I noticed in looking at your statistics before I logged on here that you have 1 death in New Zealand. Maybe you know of others, but that's all that's showing up on the Johns Hopkins site. So congratulations to you. You're not experiencing as much, well, you're not experiencing the hospital stage as much as we are, but there is that community stage. So things to be considered when the epidemic is in the community stage. The World Health Organization says that the principles of outbreak communication are trust, transparency, communicating to the public early, dialogue with the public, and planning. So here we are again, and this is familiar to me. I can't say it is to you, but this is Trump, who is speaking about, this is his daily coronavirus briefing, and the things that he says in those meetings are sometimes contradicted by others who are standing behind him. Most notably, the man behind him who has his arms crossed, that's Tony Fauci, head of the National Institutes of Allergy and Infectious Diseases, and a longtime veteran of epidemics and controversies, particularly with infectious diseases. He is at heart a scientist, and he will be conservative in what he says, careful. He'll also be forthright. And whereas politicians are more often concerned about maintaining a certain view of the public, maintaining calm, maintaining chances of re-election. So there are some other factors that come into play when politicians are talking. When the scientists are talking, it's typically more straightforward. So we haven't had a consistent message, and that has caused confusion. And in this hyper-partisan environment that we have, people tend to choose who they want to listen to. They line up into camps. And again, we don't have a unified message. The Centers for Disease Control says to employ the least restrictive interventions that are likely to be effective. This comes from a set of principles called the Syracuse principles that are when civil liberties are restricted, what kinds of guidelines should we follow? And this being one of them. If you're going to do something restrictive, use the one that is least restrictive and effective. And so here we see these 2 curves that many of us are familiar with, where the dotted line is showing the healthcare system capacity to take care of severe cases. And on the left, that hump there is when there are no protective measures like the social distancing and the hospital's overwhelmed, and those people above the curve are not getting the care that they should, and mortality is likely to be higher among them. Then with social distancing, one hopes that you can spread out the occurrence of the cases and keep the number below the health system capacity. Well, in theory, that looks great, and maybe in practice we are achieving that in many places. But the question is, how restrictive does one need to be? Early on, it didn't look like we were going to need to do as much restrictions in travel as we have done. And there was a time when countries were restricting travel and it looked unethical because it didn't seem necessary. And that was in part because we didn't know much about the virus at that time. The availability of tests was very low. We didn't understand the infectivity and the pathogenicity. We're just now beginning to figure out the number of asymptomatic cases. So we were really flying in the dark and trying to figure out just how restrictive we needed to be. And there's some evidence that you'll see here in a minute that what we're doing is having an effect. There is an obligation to care for all, to recognize and act upon the fact that the ethical obligation to provide access to healthcare is not limited to persons with citizen status only. Here in America, we have a lot of our crops harvested by people from Mexico and elsewhere in Central America. This is a group of men in North Carolina in what we'll call their barracks. And one of the questions that we have is, if one of these men gets infected, where does he go for isolation? There is no other place, which dooms all the other men to infection. If you look at the wall in the back, you'll see a little bit of black above it, and you can see that wall doesn't go to the ceiling. There's another room on the other side. So, and oftentimes we see 1, 2, 3, 4 rows of beds. Oftentimes they are all bunk beds, and you can get 18 to 20 men in a room. So this is one of the ethical questions of public health. Are we going to neglect these men? Are we going to let the epidemic just spread like wildfire among them, or are we going to create a place for them to go? It turns out that I learned just today that we are indeed going to be creating places for these men to go. Not just, let's say this guy in the front gets infected, not just him, but his other bunkmates there can be put in quarantine apart from the rest of the men to minimize the transmission amongst the camp. They're going to rent trailers and in some instances some unused hotels to keep the men there. And then of course there are the jails, and the people who are in jail cells are just sitting ducks. Many of our jails are crowded, overcrowded. And so what some cities, many cities are doing now is releasing people from jails and prison, oftentimes with ankle bracelets so that they can be tracked, sometimes just checking in with the parole officer. I'll be interested in seeing what happens after the epidemic is over and what happens to them. But there is some action to release, to minimize the density inside the prisons. Stage 3, now we're into the hospital. The Centers for Disease Control, when it comes to allocation of scarce resources, like ventilators, for example, to keep somebody breathing, should not be allocated on the basis of first come, first serve. And one has to assume that this is not to be a rule followed when you have several people in front of you who need a ventilator and you don't have one for each of them. I doubt that it would be the case if a single person were coming in and you had a ventilator and then you put them on a ventilator, you wouldn't take them off and put the next person on, except in very rare circumstances. So this is a rule that comes into play in the case of New York City, for example, where they are overwhelmed and they have far more patients than they have ventilators. They're putting multiple people on a single ventilator, as many as 4 on a single ventilator, something that's never been tried before, which has got to be quite a feat when you have to titrate the air that each person needs. And so here's a ventilator. I'm sorry, I should have been talking with the image when all through that, but here's a ventilator, and we'll talk in a minute about the gear that this physician is wearing. Ensure that public health policies and plans are sensitive to race, ethnicity, sex, sexual orientation, gender identity, and other unique characteristics of individuals affected by the policies or plans. I'm going to show you here something that deals with an inequity in the case of income. So here again, the horizontal axis is time. So it runs from February 16th to March 29th. These lines all relate to movements that were sensed by or message, not messages, GPS signals given by cell phones. So they're anonymous and aggregated, but they are aggregated by zip code or region of a particular area, and those zip codes each have average income levels. So the brown are the bottom 10% of the income levels, and the blue are the top 10% of the income levels. You get to March 8th, about halfway through, and you notice that all of the lines go down below the date line that they've got there. And this is an indication that people have enacted social distancing and they have stopped moving around as much. But you will notice that the lower income doesn't go down as far as the higher income. And the article in the New York Times that had this was titled, Social Distancing is a Luxury, that those who have wealth can do it, but then those who are, let's say, working in the Amazon storehouse to send you whatever you bought, well, they're still going to work and they're going to have more interaction with others than the wealthy are. And what the solution is to that is beyond me. Part of it surely is that the warehouses take measures to control those the transmission among those people. In fact, there has been some, I'll call them strikes, amongst Amazon workers for that very purpose. Obligations to caregivers provide preventive measures, that is prophylaxis, personal protective equipment or PPEs, infection protocols to healthcare workers in line with technical advice and updated as new epidemiologic evidence becomes available. Well, there weren't enough masks. If we go back to that preparation stage, there was an intent to build up a stockpile of masks. They didn't do it. They dropped the ball on that. And here we have a picture from the UK. The DAUK is the Doctors Association of the UK. And here they are bragging about a story of theirs that appeared in The Guardian. And it's about doctors improvising masks. And here is this one doctor who improvised one out of a snorkel. And we have other examples where people here have been improvising new masks, particularly the ones that have the plastic shield across the face. And again, just to repeat what I've said, this is an ethical issue now because the ethical issue during the preparation stage was not addressed adequately. And so it rolled downhill into the hospital, creating an ethical issue there. And now we're at the aftermath. So here we are to incorporate lessons learned from experiences into future design and implementation efforts. We should be evaluating how it all went. We need to gather input from stakeholders, people of all income levels, races, sexes, as many health professionals, farm workers, to find out how they were affected by the epidemic and the epidemic control measures, and how that should inform plans for the next time around. What went right, what didn't go right. And in doing that, one can, even within the same country, even within the same state, compare various settings because the settings are responding differently. So you saw earlier that slide comparing San Francisco and New York City. This is a different one. This is showing deaths, not cases, and it is measuring how quickly the deaths are increasing. So look at New York City in orange there, and where you see the name, I think you can see my cursor. So where you see the name here and you go a little bit left, you're going to see every 2 days. That's a track for the number of cases doubling every 2 days. So, and then down here is Chicago and New Orleans. They're on a different track. And if we had this live and I was hovering over here, Seattle would show up and it's still lower. Remember that Seattle had some of the earlier cases, but that is no longer the epicenter. It's all moved to New York City. So where we can compare these different cities and the approaches that they took and learn lessons from them to then implement in preparation for the next pandemic. And then my last bit here is to encourage policy development to protect the public's health. After you've done that evaluation, create the new policies that you need for the next time around. So here are some that are arising in this pandemic that I have not seen occur before. Notice at the bottom, cell phone tracking could help stem the spread of coronavirus. Is privacy the price? So it's possible to track an individual. You and I, those of us who have smartphones, we virtually have a tracker clamped onto our ankle as those jail prisoners I mentioned earlier, because our locations can be tracked wherever we go. That could be made available to public health to determine that, well, look at those two people in the subway, they're sitting back to back. It's possible to know that the two of them are close together because of the cell phone data, and that perhaps one of them is infected and the other one is not. And so we could do contact tracing of the uninfected one and call her in and let her know, test her perhaps, and let her know that she has been exposed. But the question is, what kind of civil liberties are we giving up to have that kind of power? It's a huge question that is thrusting itself on public health right now. And then here we are in China, where they are using drones to monitor people. On the left, you see the drones in the sky, and on the right, you see the drone's eye view of people on the ground. In the upper right of that purple cube, you can see a non-purple little square, and that's the non-tinted version. You can, if you look very closely, you squint, you can see a couple of people down there. And then the purple part is a heat sensor to determine who has a fever. So through drones, one can police and find people who have fevers, who should be in quarantine, but no, they're out on the street. And you know, who knows what's going to happen after that from the drone, or who it's going to communicate with to take care of that situation. But here again is another instance of where there is a power to do something, but do we want to use it? What kind of constraints do we want to put on this? That's one of the policies that should be considered. And now my ending few slides are to tell you that I'm in the process of developing a pandemic ethics dashboard that that collects the various, for each of the 4 stages, the typical ethical questions that arise in each of those stages, and then what guidelines are given by the standard documents, the documents that represent a consensus that I've already mentioned to you. So this is not that dashboard. This is the Johns Hopkins dashboard, but just to sort of get you warmed up thinking in terms of a dashboard. It's not a website where you can explore all kinds of different things like you would on Amazon shopping around. Note, however, that this is New Zealand data just for you that I pulled up just before this call. And you can see only 1 death and 1,106 confirmed cases. Of course, those numbers of cases vary greatly by the prevalence or the availability of testing kits. But that's just remarkable that you have had so few deaths. If I were to click on America, it's going to be way up in the thousands. So now the ethics dashboard. So we've got these 5 documents, all of which I have mentioned before in this talk. And these are the ones that represent a consensus as they were pulled together of how we should be thinking in terms of ethics in a pandemic. The Public Health Code of Ethics is not particular to a pandemic, but it has a lot of relevant information. And the way the dashboard will work is that you will go to a stage up here in this banner, Preparation Community Hospital Aftermath. This one has selected preparation. You can see it down here. On the left, common ethical issues in preparation. They're listed down here. And as you click on one, I think I clicked on collaboration in this instance, then these two columns over here populate, and you've got the various pandemic ethics documents and excerpts from them on what is said about collaboration. And then over here, statements, excerpts from the Public Health Code of Ethics. When you click on any one of these over here, you're taken to the source document so that you can read the full text and the context of what was said. And this is a quick way, particularly for policymakers in the midst of a pandemic. They don't have much time to research things, to read through all the documents to figure out what are the typical ethical responses. This will help people to quickly get to the guidance on particular issues. And that is the end. So I'm ready to hear your questions, and I'm going to stop sharing so that you can see me, and over to you.
Thank you so much, Jim. That was really good. If you have questions, you can type them in the chat window. If you can't find the chat window, down at the bottom of your screen, you should be able to click on the little chat, little speech bubble thing, and it will bring it up. So we had one question already, Jim, which we can deal with first. So from Vanessa S. asks, for the requirement of dialogue with the public, is this met through politicians or experts answering questions from the media, or are you envisaging something different for that?
In discussions that I have been in, there is something different that's envisioned. It's a good point that many of us live in representative governments. But even so, there is often more care that needs to be taken to get into the particulars of what somebody is going to experience once they are confined to their house. And so there have been listening sessions to find out about that, and that's more along the lines of what many people have been thinking about.
Thank you. I think people are probably typing out their questions, which will come through in a minute. I was going to ask, I mean, a lot of the problems that you've identified are quite big systemic, government problems. Yeah. Do you have any ideas about how to deal with that side of things?
Do I have any idea? I'm sorry?
Sorry, about dealing with the more systemic government problems. So, for example, the fact that there's a lot of unfilled positions in government and that sort of thing.
Well, let me answer it this way. I don't have a solution for that other than, how I'm going to vote in a number of months. But what I can tell you is that I've been interviewed a number of times by the press, and what the press is interested in is not those systemic issues. They're interested in, so a couple of them have asked me, is it ethical to do online shopping when you're in social distancing? Now think back on that graph where you've got the zigzags and the blue and the brown, and the lower income people were the ones who couldn't social distance as much because they're going into the warehouse to pull the things off the shelf for whatever you ordered. And so they're asking about, the press is asking about the ethics of that kind of thing. And I helped them wrestle with that, and we talked about the ways that one can ethically wrestle with that question. But I also pointed out that the reason that we are dealing with that ethical question is because bigger ethical questions before it were not dealt with sufficiently. And it's, I guess I'll just say plain, it's just not right that all of the burden should be put on individuals to think and act ethically when there are much earlier systematic places where ethical action needs to be taken. And I'll say that I was really impressed with how New Zealand acted quickly and forcefully. I don't know what your particular view of it is from New Zealand, but many of us here were saying, oh, if only, if only, if only we were doing that here. But yeah, I think your country set a good example.
Excellent. Right, we have a few more questions coming thick and fast. So from Hannah, says some people have questioned the ethical trade-off of the economic and social impact of the lockdown versus the health impacts of COVID-19, and particularly how these affect different generations differently. For example, older people are more vulnerable to COVID-19, younger people are more vulnerable to job loss and the economic impacts. Does ethical analysis of pandemics address these questions?
I haven't seen it answered in the documents that I have shared with you. I haven't seen it really addressed adequately or with any suggestion that was anticipated. This is why it's really important to have ethics committees or places where things can be wrestled with as they happen, because so much just can't be anticipated or even imagined. The one partial answer I can give to that, and it is indeed partial, it's not going to be very satisfying, is that I feel that the way to move beyond the either or, the dichotomy of either economy or lives, is to be talking about how and when are we going to retract the social distancing. That's the goal, that's the interest of all people. They want to get to that point. So let's talk about what it's going to take to get there so that we minimize the damage to the country. And I've begun to see things happening that way. It's where you see it happening is the rollout, I think they've been rolled out already, these tests to see if somebody has been infected and cured. And then people who have recovered are then supposedly, we hope they have a superpower called immunity, and they can resume work and hopefully begin to resuscitate the economy some.
Thank you. So a couple of related questions here. From Amanda de Souza asks, do children need special consideration when responding to pandemics ethically? And then Sophie has asked, do older adults need special consideration? So I guess generally, do you think special populations, particularly children and older adults, need special consideration?
Well, you know, it's interesting that so much of the ethics depends on the biology. That, you know, where the populations that this particular virus infects and the age groups, and we don't really know that until it plays out, particularly when we don't have the tests to get ahead of it. But typically we find that yes, people do need to be treated differently. The serious infection rate amongst children is much lower than it is amongst adults, but recently we've been reading that the asymptomatic rate may be as high as 50%. Tony Fauci was talking about 25 to 50% asymptomatic. So now I'm looking at the kids in my neighborhood as vectors. They're just running all over the place from one house to another. I'm speaking facetiously. I'm joking about that, but there's one or two people in my neighborhood that are not speaking facetiously when they're concerned about the young kids running around because they could conceivably infect some of the older people. I want to mention though that when it comes to the hospital setting and the allocation of scarce resources, let's just focus on ventilators for a moment. There is an ethical, I don't want to call it well, I guess it's a principle. We'll call it a principle of fair innings, like in a game, like in a baseball game, where if somebody has lived a full life, then it's somebody else's turn to live a full life. And so lesser priority is given to older people. Well, I was involved in a CDC-funded series of discussions around the world in Africa, South America, the Middle East, and Asia, grossly broad regions, but that's what the money allowed. And we went through standardized questions in each of those settings to ask, to discern how different cultures might think about pandemic ethics differently. And one of the things that came out was the attitudes towards age. In the, I'll just say broadly, Africa and African countries, they were more likely to revere age and to consider the elderly to be rare. If you think about the population pyramid in an undeveloped country, it's kind of blunt. There's a few people at the top. Is that the right way to say it, or is it sharp? There's a few people at the top and a lot of young people at the bottom, which changes their attitude in how the elderly are treated in a pandemic. Interesting. I don't know. I'd be interested in finding out in this pandemic, is that playing out? What are they doing different? But I haven't gotten to that yet.
Thank you. We are over time. I think we'll take one or two last questions from the list here, and then we will close it up. You want me to pick? Okay.
Sure.
I think the question about so New Zealand recently allowed police easier access to guns, and police are the agency enforcing physical distancing. How do we ensure that the social license given to police to operate is not compromised?
How the social license given, I mean, to protect, ensure the police don't overdo it?
Yeah, I think that's what the question is about, yeah.
Oh boy, that must be really a cultural conundrum for you all, because I think your attitude towards guns, particularly on the heels of that incident that you had a year ago, that must be really raw in your culture. Wow, that is a tough question, and it's related to the question that where I was looking at sort of the digital data advances of the drones and the use of cell phones. It's a similar thing where you've got this power, and you can believe that we're going to hear stories about how the drone prevented a terrible thing, or how the police with their guns prevented a terrible thing. And that story is going to get stuck in people's minds, and they're going to say, well, if it prevents terrible things, then let's just let it happen. One of the things that society needs to wrestle with, and it's ill-equipped to do so, is to think about, there's no such thing as zero risk. And what are the risks that we're going to allow? What are the number of deaths that we're going to allow from various sources in order to protect civil liberties, assuming we care about those? Now, you get into an authoritarian country, and the value of autonomy is less, the value of civil liberties is less, the value of protecting the whole community, and I don't know, maybe the economy too, I don't know, but protecting the whole community is a much higher value, and so very severe measures can be put into place. And there was before I was doing pandemic ethics this time around, this is the second time around I've been doing pandemic ethics. Just before, in fact, what I was going to be talking about had I come to New Zealand and before the epidemic occurred, I was going to be talking about digital data ethics in surveillance. And there are some pretty invasive types of surveillance done in populations in China. And when you read the surveys and the Chinese attitudes towards them, they're in favor of them. They don't mind. They're 70% in favor of social credit score systems, for example. So the culture varies differently. And I have totally evaded your question. I've danced all around it, but I hope you can find something in there that's useful.
It's a hard question, so thank you. I think we'll finish up there. We're 5 minutes over time already. Apologies to those of you who've asked questions that didn't have time to get answered, but thank you for asking them. And thank you, Jim, for coming to talk to us, especially given that it must be now almost 9:30 at night over there.
Yeah. I'm fine.
But thank you. That was really interesting and so topical and timely. And thank you very much.
Thank you for the opportunity.
Yeah, and for those of
Right.
you watching, this has been recorded, so if you know people who wanted to watch it who didn't get a chance, it will be available on the website at some point, and we'll send an email out about that. Okay, thank you,
All
everyone.
right. Thank you all.
Thanks.
See you next year.